So if it was challenging for the U.S. to mount a robust pandemic response during March and April, mapping out the next phases of living with this ongoing threat of the coronavirus may be even harder. While some states and major metro areas are seeing leading indicators of COVID-19 move towards the downside of the curve, loosening the restrictions that have helped get us to this point could cause outbreaks and spikes all over again. That is not stopping reopening fervor. The state of Massachusetts, one of the most cautious, is going to present its four-phase plan this coming Monday. And healthcare systems that have been on the front lines of a massive mobilization to care for the sickest patients and have witnessed more than 86,000 deaths in the United States have equally begun to strategize. How are they going to resume revenue generating services that ground to a halt more than 2 months ago? So there's no silver bullet in the face of COVID-19 and definitely no vaccine yet, but experts say there are better and worse ways to navigate the next weeks and months. And we're going to focus on those better ways with the help of two outstanding panelists: former acting administrator of the Centers for Medicare and Medicaid Services, CMS, that's Andy Slavitt, and healthcare policy analyst and physician Kavita Patel. And we welcome back IHI's Don Berwick and Derek Feely, who are our regular expert panelists on these virtual learning hours. Hello to all the panelists and hello to everyone joining us. And again, you're going to hear from our panel for the next 30 minutes, and then we'll turn to Q&A, and we're going to start with some framing and perspective from Don Berwick. So, Don, some of your thinking about the near future is captured in a recent viewpoint you wrote for JAMA. You make the point in that essay that it's less about what's going to happen to us and perhaps more about what choices we make. So, kick us off today, perhaps borrowing from some of those ideas. Welcome, Don.
Thanks, Madge, and welcome everybody. And special thanks to Kavita Patel and Andy Slavitt, close friends and colleagues of mine and people I deeply admire. They're very busy leading a lot of the thinking around the country right now, and that they would take the time to join us is flattering and extremely helpful. Thank you both. Yes, the JAMA viewpoint that I wrote at JAMA's request was they asked me to write about the new normal. What I said was, I don't know. I mean, I don't. My crystal ball is really cloudy here. In fact, Kavita and Andy have both been much more perceptive, I think, than I've been, than I'm able to be, and I look forward to hearing their predictions. I said instead of predicting, what I'd like to do is frame what COVID's brought us as choices, and so these are choices in the new normal that I outlined. I listed 6 in the article which appeared a week ago, last Monday. I said we have a choice about speed. COVID is telling us how fast we can move in research, in exchange of knowledge and information. The National Academy of Medicine stood up a standing committee in days that in 1 month issued 11 reports, which is astounding for the National Academy of Sciences, Engineering, and Medicine. That's one example. We're learning a lot about standards. I think there's always this debate about autonomy versus evidence-based care in healthcare. We're over it in COVID. I mean, people want evidence. The workforce and clinicians and organizations are just hungry for knowing what science has to tell us, and that's such a bit of a cultural change. The sincere commitment to the best science. The third I call proximity. It's really, we have a project in IHI called "Is the Office Visit a Dinosaur?" And I think COVID is kind of teaching us that we can do so much without physical contact, which is, of course, it's nice to have a visit, but if you can meet needs other ways, costs could go down and quality could go up. And I think that's what we're seeing in the COVID era. The fourth topic was workforce attitudes, protecting the workforce, honoring the workforce, making sure that, as IHI would say, joy in work is a fundamental design principle. And we lost track of that. Now, hopefully, we'll wake up a bit. Another choice is, of course, about preparedness. We're on our heels instead of on our toes, and there are reasons for that. And I just wrote a short piece on never get caught sleeping again, and we really need to understand what preparedness looks like, which also involves the choice about strengthening public health or not. We have weakened public health. Now we can strengthen it. And the last choice, the biggest one, the one we addressed in our webinar last week, is equity. This is a highly regressive virus. It's hurting people of color, or people in excluded minorities, poor people, far more than anyone else, both economically and clinically. And this is the a new manifestation of an old problem, which is that the vestiges of inequity, structural racism, and poverty are with us in a country that absolutely has to commit to getting out of that. If I wrote about that one, I'd entitle it "For Pete's Sake." Like, isn't it time to be equitable and to have healthcare be the human right it should be? So that's some of what I think. These are choices we face. Andy and Kavita can help us think more about what they think the short-term exit strategy is going to look like, and the longer term. Are we able to take advantage of these choices? Thanks for the chance to comment, Madge. I'm really looking forward to hearing our guests.
Okay, well, more from Don as the show moves on. I want to welcome Andy Slavitt, a very busy guy these days, that you were able to make some time for us. Since many people in our audience follow you on Twitter at a Slavitt, I thought we'd start with maybe a version of your State of the Union for COVID-19, particularly in the United States, but you're welcome to talk globally. You dub a series of tweets you post every Monday the State of the Union, and I asked Rachel to compile some of the ones from this past Monday on a slide. So you can reference those, or feel free to give us a sneak peek of what's likely to be said on Monday, although every day is different. Welcome, Andy.
Thank you so much. And it's a delight to talk to the IHI. I will always accept this invitation. And one day, hopefully, I'll be able to join without having to follow directly after Don, which I still which I will find intimidating for as long as I live. Um, in particular, because I think your laydown, Don, I think is as always so incredibly thoughtful. Maybe I talk a little bit about where we are and how we move forward. I mean, start with some good news. The good news is it appears that while we, of course, are dealing with a virus which is novel, we don't have immunity, it has all kinds of nasty, contagious properties and can be quite lethal in certain um, populations. It appears that there are formulas for taking this on in a way that allow people to countries to succeed and continue to move forward on a steady basis. If you look around the world, I'm impressed that whether it's the Czech Republic with mask wearing, Greece with their discipline, um, uh, the Vietnam with all of its testing, Germany with its kind of very good kind of surveillance dynamics, New Zealand with its color-coded system. Um, there are strategies that allow people to live with this virus and continue to step forward. And all of those countries are opening up their economies little by little. Um, they're going to be two steps forward, one step back for sure. Um, but so I think we should be encouraged here in the U.S. that there is an opportunity to execute and implement a strategy. It requires some things that we have not been very good at. It requires more reliance on experts than I think we've been willing to show so far in listening to the science. It requires more patience than the 3 to 4 weeks. I thought the plan announced by the White House, a task force about 4 weeks ago, had really many of the elements that a lot of us would like to see: testing, contact tracing, reduced caseloads, preparing our medical system with surge capacity and intelligence capability, isolation capabilities, and and to do that in pieces. Whether that's the perfect strategy or not, it was a strategy, and the I think we appear to have lost the patience to implement it as well as we should, and that puts us at some risk. I think um, we are living through what a lot of the epidemiologists predicted, which is that as I've heard a number of folks, including Larry Brilliant and Mike Osterholm say, we absolutely know what we need to do to contain this virus, and we absolutely know we very much doubt that the American human condition can do those things. And that's not entirely for economic reasons, although that is what might be presented. I think it's as much for cultural reasons. I think we have a country founded on principles of distrust of government. We have a country that where individual rights and freedoms are valued above social good in many cases. We have a culture where we want what we want now, every brand of toothpaste at any given moment. And so, this has been an exercise where I think the American public has really rallied, but I don't think it's one that is an experiment that is going to be able to last as long as we've been able to need it to make it last. Um, what I find interesting is that we are at a moment of some opportunity, and I say this with some knowledge that doesn't sound exactly the way we all want to hear this. But what I mean by that is we have, maybe for the first time in decades, come a point where we've actually captured the public's attention on one topic, on one area. We're not all watching different pieces of news. There actually is an opportunity to use that to spread goodness, to spread some joy, some support, some example of sacrifice, some example of courage, which all of you in the healthcare community, hospital systems, you've been demonstrating in spades with your frontline workforce. And I think sustaining that and keeping that going for a period of time will require, again, some effort, some patience, et cetera, because we are in for a bumpy ride. I'll close just by saying the following thing, which I think Don said as well, which is nobody really knows. And for anybody says, well, we're going to have a second wave in the fall, or we're going to have a steady drop off, or we're going to have, whatever they say, and you can confirm anything you want to believe. If you want to believe you're going to have a vaccine in January, you can find 5 good non-peer-reviewed articles which will support that point of view. If you want to believe that it will never have a vaccine, you can support that belief as well. There is there's just a void, and a lot of people fill in that void with facts as best they can, but a lot of us use it to complete our own narrative, whatever it is we believed coming in about this country or about experts or about our economy or anything else. The truth is, we don't know. And, I think if we don't say that pretty frequently, then, we might regret it. We don't really know how this is going to play out. We don't really know the impact of a single therapy or a cocktail. What we do know is that there are some things that work and that people do want to be careful. I do believe the country is more united than it is being portrayed, I should say. And I do think that we won't truly have our economy back until we manage through the public health crisis. I don't believe consumers start spending. I don't believe businesses start investing or hiring or signing leases while we have thousands of people a day dying to the extent that we needed to. I do believe that we will be going through an experimentation phase. But it's hard for me to blame any governor, whether it's Kemp, DeSantis, Baker, or anyone else, for trying to test what works, given that we don't know. So long as I'd like to see them do it with as much intelligence as possible, so that if something's not working, we can shut it down in 2 days instead of 10, and prevent rampant outbreaks. Cases are fine, outbreaks are not. So I think this is a little bit of where we sit. I will pass it over. I think Kavita speaking next, and she's also got so much knowledge here that I think will be helpful to hear.
Thanks, Andy. Really appreciate those thoughts. We can sort of marinate them throughout the hour. I want to pick up, I think, with Kavita, one thread of what you're saying, which is sort of the intense appreciation for all that has gone on in healthcare to respond, problems and all. And Kavita, you have the health policy side and also practicing as a physician at the same time. And I'm wondering, I think one of my questions was, is there a sort of fading light even on the some of the people who have been at the leading spear of helping through this pandemic, healthcare professionals? Are we in danger of kind of losing that focus as we sort of get swallowed up by a lot of other issues here, some of them driven by reopening? Thanks, Kavita.
Yeah, thanks so much, Madge. And if Andy feels intimidated following Don, I think I feel following Don and then Andy. So I'll try to make the most of it. But I appreciate one, the IHI is like a family. So I thank you for all those who are kind of chiming in and dialing in and chatting. I'll make a couple of points directly to address kind of what Madge asked. I don't know if it's a fading light or if it's just this kind of generalized numbness that I think the country is in, including healthcare workers, because it feels like it's just a constant kind of spin cycle, whether it's media or even in your own like community clinic or hospital environments where you feel like you're constantly talking about the same things. We don't have enough X, Y, or Z. We're nervous about reopening. And I actually think the country just writ large feels that. Having said that, it's been really humbling to see, to Andy's point, kind of this elevated. It's the one time we've got the world kind of thinking about listening to scientists. Honestly, I think a lot of people, including some of my patients, never understood what public health really was because it's just so intangible, and it's tangible. And I hate to say it, but to be honest, whatever might be fading, I'm actually hoping there's a much more dramatic light that's being placed on those topics. So I wanted to just offer, for by way of background, I'm a primary care physician. I practice in a federally qualified health center setting in the Washington, D.C. area. And it's been interesting just because our population, when Don, I always try to write down things that Don and Andy say. And when Don said it's a highly regressive virus, he couldn't be more spot on. In fact, in our region, in the DC, Maryland, Virginia, the DMV as we call it, we are seeing still a continued increase in cases. So we're incredibly nervous about reopenings surrounding us because we know that states and cities are not hermetically sealed. So I think, so I'll take this just a couple of comments as a healthcare provider. Just practically speaking, our clinics, we had 13 clinics in this region, and we actually had to close 7 of them, both because of reduced volume, as well a mix in the beginning of reduced volume and actually staff shortages, furloughs, a combination of economic consequences. The truth is that even in a predominantly COVID-19 telehealth friendly environment, we just couldn't keep the money to keep the buildings open. And it wasn't the right thing to do health wise. We don't know coming out of this if we're going to be back to, in fact, none of us think we'll be back to quote normal. However, also in our region, hospital volume, ICU hospitalizations are going down. We still have COVID patients in all of our major hospitals in the ICUs and in the COVID floors, but pop-up tents are closing, and we're certainly seeing a decrease in hospital volume, pairing that, of course, with new cases that aren't necessarily hospitalized. So all of our area hospitals have opened up elective procedures, and I feel like in the IHI community, a lot of us are in the same boat. And a lot of us are having the exact discussion I bet you are, where all patients who are coming into the hospital for any procedure, elective or otherwise, are being asked to be tested in advance. And last night, we just had a very spirited conversation about what do we do with false negatives now that we're hearing that there could be a proportion of false negatives. And it's calling into question. So, just some takeaways. I think that if your hospital, every clinic I know of has some sort of COVID committee or task force. I would strongly encourage those of you that are in a hospital based setting to link to people like me who are in a clinic based setting, because it's now more than ever that I think we're going to actually need a robust primary care preventive task force. Something I've been saying is that flattening the curve is going to depend on primary care. So the fading light in a way, Madge, is less about fading on all of healthcare professionals, but I'm actually hoping we spark a generational ignition on public health professionals and primary care in order to have some really confidence that we're not sending children and parents into hospital settings at putting health professionals and themselves at risk. The second lesson, kind of on quote the other side of this, been interesting, is in places like Boston and New York, and I know we have folks from Puerto Rico, all around the world on this webinar. We're learning that we actually can take care of people virtually, and it's good. So we're striking a balance. In fact, a conversation I had this morning with our clinic medical directors is like, what proportion of our care should we continue in a virtual manner? And we're trying to risk stratify for the people who are the most vulnerable, but we're also going to try to do what we can to bring people in, because I'm an internist, but we've got family medicine and pediatricians. We have children who have not come in for vaccinations. And we also have, we in our clinic setting, we do integrated behavioral health and dental care. We have children who have not had dental visits, who actually have like the need, and adults as well. So we're actually talking literally about virtual dental visits, which I didn't even think was possible, but we're learning how much we can push the limits effectively and with high quality. But we're also trying to strike a balance now on how to bring people in for things we just can't do virtually. The third, so first takeaway point is, if you are in a hospital-based setting, start reaching out to make kind of these clinic integrations. Second is really thinking about kind of forward leaning. How can you allocate staffing to do a mix of virtual and in-person if you're in a more clinic-based setting? And then the third lesson is that I do believe, as healthcare professionals, I actually read last night the CDC released interim guidance on contact tracing, 64 pages for very fun reading. I'm actually going to ask all of my clinic cohort members, including my medical assistants, to read some kind of simplified version of that. I believe that we're going to, the story, I don't need to repeat. We need to do more testing. We're doing about 270 to 300,000 tests a day. And we also need to do tracing, standing up a kind of a generation of army and whatever you want to call it of tracers is hard. It's actually something a lot of us, though, in the health professions can do if we kind of refresh our thinking. So my third kind of takeaway point is that on the other side of this are currently setting in skills for your staff, whether you're in a highly quaternary trained center or in kind of one of these frontline small solo practices, trying to think about how you can integrate contact tracing, because I do believe flattening the curve, whether we go through a second wave or little spikes in your own communities, we're going to need to do that. Oh, and then I was only going to make 3 points, but I have to make this. Health literacy is such a critical functional piece of making this work. Because of the kind of setting I work in, majority of my patients speak Spanish. And a lot of what we talk about doesn't actually translate. And then for the African Americans that I treat, I actually had a candid conversation with a mom of 3 sons who said, putting a mask on a Black boy is not easy to do, because I'm worried that that's going to make people think at night that they're trying to rob my stores. And, it's a very frank discussion about some real issues. And I think as a country, we have to accept that telling people to wear non-medical masks and social distancing and some of those things just don't translate well. And so I do hope that there's this amazing Harvard medical student, Pooja, and I was going to try to find her name. She started this kind of open project. I'll get it and put it in the chat box for those who are interested. And her nonprofit, because Harvard medical students are sitting around, they can't do anything right now. Her nonprofit has put together 20 language assessments for explaining COVID. And I think that's brilliant. So for me, those are hopefully some key points. And I'm a policy person. So, I bug people like Andy and Don who run CMS to think about how do we lift some of this to translate back to policy changes that allow for more flexible, sites of care, that allow for that kind of opportunity to do things virtually, but be able to keep your practice open and whole. So I'll stop there, because I think probably there'll be a good deal of discussion we can have. So thank you for giving me this opportunity.
It's a great intersection, Kavita, where you stand in terms of your knowledge base and experience. And it's kind of perfect, really, for this conversation, because that's going to be the dynamic, is sort of understanding potential policy, what practice looks like, and what people need. And thank you. So all good stuff to think about there. I'm going to bring Derek Feely in now. Derek has 1 foot in the United States, 1 foot in Europe, I guess, and also often sees things from a very interesting lens. So, Derek, some of your reflections. Thanks.
I'm still in the US, at least for the rest of this day, Madge, although I am wearing my plaid shirt, as you can perhaps see. And so I was beginning to feel a bit sorry for Andy for having to follow Dawn and Kavita for having to follow both of them, and then I remembered that you were going to come to me next. So a lot of what Andy and Kavita said resonated with me. I particularly liked Andy's point about caution and thoughtfulness and let's take a considered move into this next phase. And I like Andy, I do take some solace in the fact that that does seem to be what the majority of the population are saying. You know, in the US, notwithstanding the tendency towards individual rights and the distrust of government, still 70% of people think that, let's be cautious with this reopening. Let's go piece by piece. They're nervous about some of the rush to reopen, and they understand that the best way to reopen the economy is to deal with the health challenge. There's a report just back home in Scotland released today, which shows over 80% of the Scottish population saying the same kind of thing. And so we ought to return to whatever normal is going to be in the future. We ought to make some of those choices that Dawn identified for us in a thoughtful, considered, and cautious kind of way, because that's what the population expects us to do. A couple of other thoughts from me, Madge. I think we ought to be careful that we don't falsely equate a return to normal with a return to the past. And at the forefront of the new normal, we need to pay attention to some of the things I think that we've talked about in previous iterations of this show. So like equity. And as we said last week, COVID-19 didn't create this inequity, but it has shone a spotlight on it, and the future just needs to be just, and it needs to be equitable. And how can we take full advantage of the spotlight that has been shone on us? How do we mobilize people to redesign our systems with equity in mind? Like some of the enhancements to primary care that Kavita mentioned. You know, we've been talking about those things for 20 years. Let's go on and do some of them now. Can we finally begin to deploy safe and reliable telehealth where it meets patients' needs, just as we rethink our primary care? The other thing I think that Dawn touched on this in his introductory remarks, and I think we need to pay a lot of attention to in this next phase is, let's be sure that we create an environment for our workforce that's safe, physically and psychologically. An environment that brings people meaning and purpose and joy in work, rather than exposes them to risk and danger and stress. I think that's one example where we just need to be better prepared in the future. We can't stumble into another situation just inadequately providing the basic essentials like PPE. And finally, I do want to stress a point we've made on this weekly program before, and Don referred to in the chat. We need to take this opportunity to create some kind of global community that's based on generosity and shared learning and a commitment to improving quality and improving outcomes for people. If ever there was a time to recognize that none of us thrives unless all of us thrive, that this is not a time for one country first. This is a time for everybody together. Well, this is it. So those are a few things, Madge, I think we need to pay attention to as we move into this next phase. Keen to hear more from Andy and Kavita.
Thanks, Derek. All right, we're going to turn to the chat in just a minute, and thank you all for some of your comments and also suggestions already. One of the things I always love about these programs is that you find people very solutions oriented, which is very, very helpful, because I think we're all treated to the din of conflict and a lot of division in this. That said, so I want to ask one question very maybe quickly, if there's a sort of a concise answer to this, to Andy maybe. Do we have a way forward? It seems this was what your theme was maybe suggesting, or hopeful idea here, that we can get to a point where we're not trying to contrast how many deaths are we willing to sacrifice to reopen the economy. These sort of zero-sum solutions, that's how the debate kind of gets sorted out, or feast or famine, or it's now or never. And on any given day, we can all point to the stories we're hearing, or the coverage, or the commentary that suggests that's the tension. What might be your thoughts, particularly thinking about a lot of people who work in healthcare in this audience, about how to navigate that? Who should they be paying attention to, if not all these headlines? Thanks, Andy.
Yeah, well, look, the rhetoric is going to have a life of its own, driven by a number of things, including the political cycle, including kind of our never-ending search for a bad guy, whether it's China, whether it's Obama, whether it's Trump. We seem to be blaming the virus least of all. By the way, we seem to be blaming. That's not as interesting a cable news headline, because there's nobody who comes on TV to defend the virus, so you can't have a good debate. Although, give us time, maybe there will be somebody. The thing that I think is at the heart of kind of the debate versus the reality on the economy and so on is that, like, I find it very helpful to remind myself every day that there's not a person who wants more people to die needlessly, and there's not a person that wants small businesses to not be able to open before their time. Everybody wants the same thing, and we're having a spirited argument over something nobody knows the answer to, which is what's the best path. And I think we should all try to assume as much positive intent as much as possible, no matter who tries to heat us up. I do think that it's quite possible that we will find a set of activities that are basically safe, that we are not so sure if they're safe. And so, we stayed home to crush or at least to flatten the curve. And, I think we're getting worked up because people are congregating in parks in small numbers, and we're taking photographs and saying, look, I looked at some of the cell phone data yesterday, and I think people are still going to be cautious. Now, again, as Derek said, sometimes you're only as good as your least cautious person in your community. So there's absolutely the opportunity for outbreaks still, but people are not, mathematical terms, if we're going to go from a 0.97 R naught, we're not going to go back to 2.3. We're going to go back to, 1.3, which is not good. This is no way to beat a virus. But if it's the right 1.3 and if it's manageable, and realistically, I think we can figure out how to muddle our way through. So my advice to people is listen to people who tell you all the time that they don't know the answer. Listen to more than one person. Don't just have one source. Listen to our public health commissioners. Most of them are good. Some of them are not. Don't listen to the bad ones. Um, and and then try, and sometimes it's hard because we're all wired up this way. Try to understand that our political leaders, to the extent that they're listening and making not decisions that we think are the best decisions, um, are trying and need to be influenced and hopefully can adjust quickly. It's the adjust quickly part that I think is so important because there's no perfect way through it.
Thanks. Good thoughts. Kavita, let me ask you, I'm going to turn now in earnest, although we are looking, definitely everyone, at your comments and questions in the chat. Two things I'm going to relate to one another, and one has to do with the effective precautions, Kavita, you spoke of in the area of the DC area you're talking about. Maryland also and Virginia in that people actually elective surgery restarting. So folks are coming in. And that's what we're going to have to do is keep learning from where things are happening. Somebody is asking about proactive things that might need to be put in place to assure this efficiency around testing, screening of visitors, staff, who are making appointments, coming in, et cetera. So that was one thing. And then I think there's an interesting, bigger question that somebody has asked is what is the value? We keep hearing about antibody testing.
Yeah.
And from the healthcare system's perspective, if possible, and maybe Andy thinking about it also policy-wise, what is the value of that? Really? Kavita, you first.
Yeah, sure. I'll start. And by the way, this is all being kind of, I would say this is one of those fast moving topics that perhaps in a month it'll be an incredibly different answer I would give. Certainly changed from a month ago. To your first point about elective procedures, I've been a little distressed at the variability in policies between hospitals about universal testing of their own workers. So there's not necessarily what I would suggest for those of you that have the ability. I realize there's still shortages in many areas around swabs and supplies. For those that are either accessing the antigen test, which does have a much kind of easier turnaround, still has the sensitivity and specificity is not 100, so you still have to take that into consideration. I would strongly encourage any hospital that can to kind of deploy like this antigen-wide testing, or at a minimum all the workers, and that includes every level of workers. And then of course people are coming in. The problem is unfortunately that the process, again, this is why hospitals need to have some really direct links with the high referring physicians who are sending people in for procedures and imaging, et cetera. And you need to have a process that kind of is turnkey about testing, but not just testing. To your point, I think about where do we deal with false negatives or even false positives as we're finding them? We need to actually kind of almost do like an inventory, not just the CDC-6 symptoms, but also testing. And then I would validate kind of household contacts, things like that, in the event that you do need to turn that around to be a contact tracing event. So I would think through those protocols. I know every hospital is limiting entrances, doing infrared thermometer checks. Those have, a very low percentage. It's better than nothing. But then obviously as elective procedures are coming open, you just want to be able to catch the hot spots. So that's a very practical tip. On the antibody testing, as we know that there's a lot of antibody testing itself, it's still unclear what kind of immunity that might confer, if it does confer. I think that in non-human primates, we've seen enough evidence to demonstrate that if you do have IgG antibodies, that there is likely a short-term, what does that mean, months of immunity. However, given the variability of the performance of the antibody tests, it does create kind of a false hope if you use seroprevalence or antibody testing as only a mechanism to ensure, there should be no reason that an antibody test outcome changes the precautions you put into place. I guess that's the bottom line. If you're in a hospital, if you're in a clinic, if you are an individual who has one of those tests that says my IgG is positive, that might give you some internal security. It should not change your behaviors. And if we're in a healthcare setting, that would be what I would emphasize. Having said that, there is going to be, as people return to work, an incredible demand for it. In fact, it is one of the most popular requests I'm getting. And I'm often forced in a televisit to say, you don't need this because I don't know what it means. But people who are going back to work or have been at work, essential workers, feel like they need to have it. Just another point, yesterday in JAMA, there was an article, first of its kind, written about seroconversion in the healthcare setting in a pediatric dialysis unit in Indiana, I believe, where healthcare workers who were not in direct contact with COVID positive patients showed up with antibodies. Only 2 of them had had symptoms. The other 9 that seroconverted did not have any symptoms. What do we do with that? I think that for me in a healthcare setting, that means my bar needs to be raised on precautions. So where I'm actually passing that article around, 11 healthcare workers, I don't know how to generalize it, but it's caused me to reinforce that we really do need to think about PPE precautions and who in what settings needs to take those precautions.
Thanks. Andy, any thoughts at all about kind of where the flow of attention? And I'm going to throw in one other edgy, maybe not so edgy question, which is at the outset of this pandemic, and Derek and Don can attest to sort of IHI stance. We were very clear. We're following WHO. We're following the CDC guidelines. We're taking our cues and understanding from these very reputable sources. As we continue to move forward, should anybody be concerned, let's say here in the good old USA, that the CDC in any way is getting politicized in such a way that could be raise questions and doubts? And do we still have that sort of stable sense of this voice matters? You don't question this voice, even with all our controversies.
Yeah, I mean, just a couple quick reactions. First of all, on antibody tests, I think this is where Kavita was. I think they're far less useful, and I hope they never become extremely useful. They're obviously useful in New York, but I'm not someone who's a big fan of the Sweden herd immunity strategy. The costs of that are way too high unless we have some magic therapies. So I hope that I understand why individuals want to know, and I think it's good for us to continue to take the pulse of the population with these tests. But otherwise, the diagnostic tests are just far more important to me, at least. In terms of the CDC, my fear is that the administration is almost painting the CDC the way it has painted the EPA, Environmental Protection Agency, which is pointy-headed scientists trying to get in the way of the president's economic policies and goals, and a restraint on his agenda and on commerce more broadly. And I wrote last night, it's like, you want your scientists to give you scientific advice, you want your economists to give you economic advice, and you want a good process, and you don't want the CDC. So people are getting, I think, stirring up in certain circles resentment and discrediting the CDC. And look, they've been far from perfect. And if you want to find opportunities to show where science has been wrong, that's exactly what science is all about. It's about analyzing and a discovery process. And so it's not hard. It won't be hard for people to discredit should, in this day and age, people want to use social media, other kinds of media, whatever, to paint these organizations as just wrong. But that's not the point. I mean, the point is, you rely on a set of experts like this, even when, and if they're not performing at the top of their game, they play a really critical role. And to dismiss out of whole cloth experts and be able to write them off as, either wanting to destroy the economy or being political or being wrong, and therefore disqualified, is a dangerous and I think cynical practice. And it's not that it doesn't have roots in our country, by the way, and it's not that it doesn't have roots in this White House. And I don't say that to be political, but the as soon as you can label someone an unelected bureaucrat, you can sort of diminish them. We're seeing that happen with some of our best scientists right now, and I think it's dangerous. So I hope that the CDC and the WHO, who's been even more discredited, and I could go on about that at another time, just keep doing their jobs, kind of put on, as I think they are good at doing, put the information out, and it's the best that they can do.
Don, building maybe on some of Andy's, I'm sure you've been thinking a lot about this too. And somebody in the comment section you may see is still thinking about yours, something you've maybe written, which I don't know, we have to find that, Don. We never want to be caught sleeping, which is great, a great thought. So maybe connect some of those dots for us about and another person has said something very interesting. I know it would be something you and Derek would love too, which is let's catch healthcare professionals doing good things and the right things and start shining some lights there. So as usual, I've thrown 3 or 4 things at you, Don, but you're a master, so go for it. Thanks.
Well, we're hearing a lot of wisdom from Kavita and Andy and Derek. I guess the thing that's catching my ear most goes back to Andy's comment, with which I thoroughly agree, that we don't know. We're navigating into pretty unfamiliar waters here. Even the question about antibody testing, we are, in a month, we're going to know a ton more about the immune processes here and their durability and so on. So we're learning really fast. Science is learning. We're all learning. But there is this challenge that Andy put out about, can we learn from the variation in the way we're dealing with this? So I want to look ahead, not back, for a minute. For whatever reasons, we're seeing states and localities differ in the way they're dealing with this, emerging with different strategies and plans. Some seem unwise, some seem more moderate, but as we know in the quality improvement world, variation can be a teacher if we make it systematic. I don't remember the exact language Andy used when he mentioned this, but I guess that's a big question of mine. Are we going to learn? Can we learn from this? Even even a Georgia or or Montana, some place that's going out on a limb. I don't know the answer to that, but looking ahead, I'd love to know what Andy and Kavita think about that. Can we be a learning nation, really? Because the potential for being smarter, for getting smarter fast, is really here. And anyway, I'm not sure that's exactly what you're asking me to opine on, Madge, but I think it's a big deal.
It's a good question. Kavita, you want to take a stab at that first?
Sure.
You suggested something, I think, earlier about trying to learn from what's happening in your very area there.
Yeah, no, to be honest, it's actually my IHI kind of teachings that kind of made me think we need a learning collaborative. And if you reflect on a bit, I think Don actually worked on some of the original kind of thinking around the learning health system, but expanding that to kind of the community as well. So how can we create, and the way we're trying to do it is with information exchange. Indiana is doing a great job. They've got Regan Streif in their backyard, and I actually think they're doing an incredible job getting input from all the area hospitals. Those of you that are interested, I would highly recommend just Google Regan Streif Institute, and you'll see how they're trying to share best practices across the private and public sectors. Oh, and that brings me to another point. I think Don's spot on, and building on Andy's comments, a lot of the learning we need to do is going to come from employers who are feeling quite paralyzed by a lot of things. A Washington Post article today said that a good number of people returning to work are worried that they could bring the virus into their families. So in healthcare, a lot of us are trying to think about, ways to expand our reach for purposes of, revenue generation. In this time, there's actually an incredible need for that, because our learning is going to have to be shared with schools and employers. If you look at the CDC guidance on reopening schools, it asks a lot of things of schools that even in my kids are young, in my son's school with the highest levels of input, they're not going to be able to figure out on their own. And so I think this is an incredible opportunity, whether it's virtual or whether it's like micro in your communities, to make these alliances and reach out, because on the other side, they're going to be desperate for some of that help.
I,
Go
I
ahead.
think so. Actually, one of the most interesting conversations that I've had was with Nate Silver. I interviewed him for my podcast in the Bubble. If y'all want to listen to it, it was amazing. And what Nate Silver does, he's the 538 guy, is he helps you understand the biases that even all of us bring to these conversations and thought processes, because he's just very much driven by the data, and he's not a public health expert. And so I laid down this very neat theory to him about California's response versus New York's response, and why New York responded later, and that's why with exponential math they had more cases, blah 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 blah. And he goes, yeah, maybe, but that's dangerous thinking. And I said, why? He goes, because you're trying to fit a fact pattern. He goes, look, it's quite possible that there was one person who was, in Florida, who was a super spreader and who decided to take a trip to New York instead of California. And that person, because we know that some people are highly infectious and some people not at all, that literally that one person could have made the difference between what New York experienced and what California experienced. If he'd have taken a trip to California or Chicago or some other city, things could be completely different. And he said, I think there's at least a third probability that something random is happening that we can't measure, we can't explain. And so we try to fit these fact patterns. And, when I thought about it that way, I realized how much I'm trying to create my own neat narrative of how these things work. And so Don's point about learning is exactly right. If we act like we're going in and we know it all, like, oh, Georgia's going to be a hellhole, or Florida's going to be a hellhole, or whatever it is, things are working out in different and interesting ways. I mean, I'm looking at the cell phone data in Georgia yesterday, and people have come off of they've come off of their distancing a little bit, but they're maybe 10% of the way back towards where they were before the virus. And so who knows? Who knows? And again, I think Don's right. I mean, we've got to learn about this stuff, and there may be some uncontrollables that are part of the mix. There's a lot that's controllable, we know, and we should work on those things. But it's not going to be an R squared. It's not going to be like an R squared of like 0.95. It may be like 0.6 or something.
Well, I have that unenviable task of trying to bring our program to some sort of satisfying and maybe satisfactory end today. And part of it is to say that we're just going to keep talking, all of us. Somebody in the chat wondered if they would continue to have access to the speakers, and the answer is yes. I can't remember if we put everybody's email addresses on their bio slides. We do that sometimes on virtual learning hours, but we can find out how people feel about that. But Andy Slavitt has all kinds of good ways that you can keep track of what he's thinking about, and tweeted him on Twitter and in the Bubble, a relatively new podcast, which I've listened to, and it's great. Kavita Patel is very approachable, and very has wonderful ways of putting things together. And certainly Don and Derek are reachable through all of us here at IHI. So I want to encourage you to do that. These are some of the voices that we'll continue to rely upon. Um, Also, I do want to mention people who were asking about some things related to telemedicine. We are doing a fair amount of work in that space at IHI, so watch us as we continue to put things out. We had a virtual learning hour a few weeks ago on telemedicine, trying to get some big picture ideas. IHI is working on some quality and safety considerations to make sure they're part of the zeal and the convenience and the effectiveness, as Kavita was mentioning before, of telemedicine. What should we keep? And of course, we'll be watching to see what happens with rules and regs that were loosened temporarily, what's going to stick around. Also, I'm hoping next week that we get some of the key people on board to join me and Don and Derek and the team to talk about this issue of starting up elective surgeries and procedures again. We're got a feeler out to Geisinger, and if you're on the phone here today, Geisinger, I reached out to see if we could maybe get some of your plans as part of our program. So I want to, again, thanks for taking a look at that survey on the right-hand side of your screen, because that helps us keep doing something worthwhile for you. I want to thank Kavita Patel, Andy Slavitt, Don Berwick, and Derek Feely. Thank you, audience, for taking the time to participate. Ask questions, make comments, keep networking with one another. Be on the lookout for the archived edition of this program getting posted to our website later today and no later than Monday. And we're going to be back next Friday at 10 a.m. With another program. Details soon on our website. It is my honor times 10. I don't know, to the 10th power to be doing this program. I'm learning constantly. I hope all of you are too. We wish you all the best. We wish you good health for the Institute for Healthcare Improvement. Thanks for joining. I'm Madge Kaplan.